So as soon as a child enters your room, what will you look for? First is a abnormal head posture, because that is the best time to assess for a abnormal head posture before the child becomes conscious. They are not very aware. They will be fixing at something, and if you notice it, for this you need not do a full examination. Just the preliminary look, you will get this finding. Then comes nystagmus. If it is there, it has to be noted. Squeezing of the eye and any obvious squint. And ask for vision problems if who is Ravi Matani requesting control. Then how to examine? So first we will do vision testing, then refraction, then assessment of binocular vision. I'll tell you why. First, the sensory evaluation has to be done, and then only we'll go for the actual motor evaluation by cover test. And a detailed eye checkup is important part of every squint evaluation. Squint evaluation doesn't mean only the squint has to be evaluated, because we need to know the reason for the squint also. And just for example, a child having a toxoplasma scar in the retina and squint. So if we miss that scar, then we will take it as a normal exotropia, start patching, and that we will not be in a right direction. So if it is a toxoplasma scar, then we know that it is a sensory exotropia. So based on that, our treatment plan changes. So that detailed examination is also important. And second, let's why sensory evaluation. First, you should be aware of what is sensory evaluation and what is motor evaluation. Point number 3 is sensory evaluation. Point number 4 is motor evaluation. By sensory evaluation, we mean we will test the binocular vision and stereopsis of the child by word for dot test and a stereo chart. Because once you do the motor, start doing the motor examination and you start doing cover test, you break the fusion of the child. So that will affect the sensory evaluation once the fusion is broken. That is why it has to be done first before attempting for motor evaluation. Now, this is a slight overlap from yesterday's presentation, but for completion's sake, I'm doing it, and also for the new people who have joined today. In infants or a pre-verbal child, the most easiest way to assess vision or fixation is the fixation pattern. What do we mean by fixation pattern? Fixation pattern is in very young child, it can be fixing to torchlight in both the eyes separately or binocularly as well. Or if in older child, it can be done in terms of central or uncentral, steady or unsteady, and maintained or unmaintained. These are some of the charts that are used for preferential looking tests in pre-verbal children for vision assessment. Now, in preschool but verbal child, there are various charts available, anyone we can use, and the most common available to us is the Lee symbol. This is what we use in our hospital, and most of the big places, this chart is used for vision assessment. What all do we need for squint evaluation? I'll play this. It's not playing. So go through this. All the unique instruments that are required will be
Can you
there
make
in
it on
this.
full screen, please?
One.
Good.
Yeah. So as you can see, you have sorry. as you can see, you have a trial chart, the near stereo, the prism, loose prism set. Then for Worth dot test, you have these spectacles. The near Worth dot test, you have that torch. And for stereopsis, you have the chart. So, and small toys to gather attention of the child. So these are small, it doesn't require much of investment. The Squint is one of the lightest in terms of investment required for setup. So this also we have covered yesterday, and just a short one or two slide. The dilating protocol, we should be aware that older than 1 year, the children are dilated with cyclopentolate, tropicamide, and cyclopentolate. And if they are having neurological problem, then homatropin combined with the tropicamide. Less than 1 year, plain tropicamide is used, and atropine in very selected cases where we suspect ciliary spasm. So whatever we covered yesterday, I have skipped that. Now coming to sensory evaluation. So there are various charts, the most common being Titmus fly chart, by which we can do the test. For that, we need a polarized spectacles. And then which one is raised, which part is raised, the child has to be examined. And they will keep on telling it will start from 400 arc seconds, and the best performance is around 40 arc seconds. So a children with a good binocular vision can go up to 40, but anything 100 or less is considered to be good. One important suggestion during this time when we are facing the COVID problem, yesterday we had a discussion in a select group of pediatric ophthalmologists from all over the country. It was suggested that we don't do stereopsis right now till the pandemic is there, because same book being handled by multiple children, chances of spreading the infection is there. So that we have to be careful only for the pandemic period. Now comes the test for fusion, which is the Worth dot test. How do we test it? Red for the right eye and green for the left eye. That has to be the how we use the spectacles, and then the child has to tell what they see in the 4 dots, what they are seeing, how many red, how many green, how many white. Based on that, our assessment will be done. And same thing has to be done for near also, because again peripheral fusion, the distance gives the central fusion, and the near Worth dot test gives the peripheral fusion value. So how do we interpret it? As you can see, red is in front of the right eye, R and R. That is how we remember it. So when the child is seeing one red, one white, or a slight orange, and two green, that is good fusion. That is binocular vision. If the child is seeing only the red, then how do we interpret it? Because red lens is in front of the right eye. So he is using only the right eye, the left one is suppressed. So two reds means left is suppressed. Same thing if the child is seeing three green, that means two green, the white one also he or she is seeing as green, but not the red dot. That means the left is dominant and right is suppressed. And then at the same time, if he is seeing three green and two red, the interpretation will be diplopia. So this is very simple. Once you understand the concept, the interpretation is very simple. So once we have done, this is the sensory part, and sensory evaluation is also always done binocularly. So and this is why we don't do cover test before the sensory evaluation, because we don't want to break fusion, which will affect the test. Once that is complete, then comes the assessment, the motor assessment. Now, what we have to know is cover uncover test. Various tests are there. Uncover test, what we know from uncover test is the foria component. Cover test is for the tropia component. And alternate cover test will be for total deviation, which includes both the foria and tropia. Hope all of you are aware about foria and tropia. Foria is the latent component, the latent squint. Foria, that is called foria. Tropia is the manifest component. So any squint can have a combination of both latent and manifest component that comes with the alternate cover test. Now, how do we do the cover test? Because for cover test to be done, the basic prerequisite is the child should be able to comprehend our command. Whatever we are telling, that the child should be, if we are telling them to fix at one point, then the child, that has to be done. And vision should be at least 6 by 60, so that one distance fixation point, the first letter of the child is able to fix on that. And ocular motility, definitely, if it is good ocular motility, full ocular motility will give a more reliable cover test reading. And what does the patient wear? We never do a cover test without the spectacles. If the child is having spectacles, then the cover test has to be done with the spectacle on. There is no relevance of cover test without spectacles. And how do we cover it? We can cover with either our thumb, palm, or a occluder. So this, if these criteria is met, then we go ahead with cover test. Many times you will have parents who will complain that, sir, uska squint hota hai. There is a squint in the eye, and that especially in the accommodative azotropias. Then give them a leading question whether the squint is there with the spectacles on or without the spectacles, and 99% of the time they will tell without the spectacles. So then you have to explain to them that any squint that has to be assessed is with the spectacles on. Squint without spectacles is of no relevance at all. If we are not able to explain to them, they will keep on running from one doctor to another because their question remains unanswered. And now,
One
huh,
one question is there from Dr. Brijesh
yeah,
in that 3-4 slides behind worth for dot test, that in the right eye you wear green glasses and in the left you wear red. That is what he says is written in Kansky. That is in the chat box.
is
You
it?
can see his question.
That is the mistake in the Kansky.
No, no, that is wrong. That is wrong.
That is wrong.
Hmm.
That printing mistake is since long.
Hmm. Hmm.
Okay, so I hope Dr. Bridges that answers your question. And sir, what is the difference between Krimsky and modified Krimsky?
I'll go in the subsequent slide. It will be there.
Okay, thank you. Go ahead.
So when we do the first, what we do is cover the fixing eye and watch for the other eye. Just this will require some concentration. When one eye is fixing, we cover that. Suppose right eye is fixing, left eye or if you're not sure about squint, then any of the eye is covered and watch for the other eye. And then do you see any movement? If you see, yes, the eye moved in or out or up or down, uh, that is tropia. And if you're not sure, then cover again and watch still, and then go to step 2. So first step, when you cover any one of the eye and the other eye is deviating, then the child is having tropia, that is manifest squint. And when you cover one of the eye, first any of the eye, and if there is no movement, then we go to step 2. Then what options are there? Either the eyes are straight, orthophoria, or there is a latent squint. So we have to, in the next step, we'll know whether the child is having a latent squint or a orthotropia. So let us see this carefully. In this, the right eye is being covered. And what do you see? Once the right eye is covered, the left eye takes fixation. But when the left eye is being covered, right eye doesn't move. What does this show? And again, important, this is very important to know the fixation pattern of the eye, because this will give us a good idea as to which eye is amblyopic. See this again, right eye being covered, left eye was deviated, takes fixation. When right eye is being uncovered, left eye goes out again. That means fixation of the left eye is central. Central means there is no eccentric fixation. When the left eye is fixing, it is taking a central fixation. Steady or unsteady is whether the child is having nystagmus or not. So in this case, there is no nystagmus. So it is steady. Third is maintained or unmaintained. The left eye here is unmaintained. Why? Because when you are covering the right eye, left eye takes central fixation, but as soon as you remove the cover from the right eye, left eye deviates again. So that is called unmaintained fixation. And the right eye fixation will be central, steady, and maintained. Many times when our optometrists are doing workup, they will mention central steady unmaintained right eye, central steady unmaintained left eye. That is impossible. If one eye is unmaintained, then the other eye will be maintained. So these concepts have to be clear. Unsteady, yeah, most of the cases unsteady is binocular. Both eye will have nystagmus. So central unsteady maintained and central unsteady unmaintained or maintained can be there. And same thing needs to be done for near, and it is very important for near to give a accommodative. Yeah, any question? No. Same thing has to be done for near, and for near it is very important that we give a accommodative target to the child. We cannot do it with a torchlight. Torchlight is not accommodative target. We have to give a small the accommodative target to the child when we are doing the same test for near. Now watch the uncovered eye and if there is any movement. So if one situation in which you cover one of the eye and there is no movement, so that time when you uncover the covered eye, look for movement, any recovery movement behind, if it is there or not. If it is, then that is a latent squint. So we know that the child is having a latent squint also. So we have to remember cover test is for manifest squint, uncovered test is for latent squint. Then comes the quantitative assessment. So quantitative assessment can be either a corneal reflex test, which is called Hirschberg, and this is a very crude way which sometimes we can do when the child is not cooperating too much. Then we do the Hirschberg test, and based on what is written, we can give a rough calculation of the angle of the squint. Then comes the alternate prism cover test. With alternate prism cover test, what we are doing, the rule is that apex of the prism will be towards the deviation of the eye. So in this case, as you can see, the prism has been kept with base in. One prism is with base in and other prism is with base down. So in this child is having a exotropia and R over L, right hypertropia. So, and another important point here is we cannot stack like here, two different directions, the prisms are stacked together, but we cannot stack two prisms in the same direction. Like if we want to give a base in prism and with the loose prism, the maximum reading available to us is 50 prism diopter. So if the squint is more than 50 prism diopter, then the additional angle has to be kept above in front of the other eye. We cannot stack it in front of the same eye. But when it is in two different directions, like here, one is based in and based down, then it can be stacked. And simultaneous prism cover test we can do. And again, with this, we'll get to some idea about the tropia, not the phoria part. Now, next comes the question after this. Now, this is one of the method. Then we have a Krimsky or modified Krimsky test for squint evaluation. Now, in Krimsky test, what we do is that we put the prism in front of the deviated eye, the amblyoptic eye, and then look for the Hirschberg, the central corneal reflex. And but in modified Krimsky, and Krimsky is not practiced now. In modified Krimsky, we put the prism in front of the better eye. So in this case, suppose this child was having left exotropia, so the prism will be kept in front of the right eye, and then the central corneal reflex has to be brought, and then we get a rough idea of the squint angle, and it is done for near. Again, these are for children who are not cooperating and who do not qualify for the prerequisites of the cover test, like their vision is very bad, then it is 660 or less. Then after this, we do the ocular motility test. Once the squint evaluation has been done, then the ocular motility test is done, and it has to be done in all 9 gazes. And we have to know that which gaze represents which muscle. So, for example, play again and show you. This is
Manish, can we mute everybody else? Manish, can we mute everybody else?
It is muted, sir. I think Dr. Love he can unmute.
This is a test for left lateral rectus and right medial rectus. Okay. Now, left lateral rectus and right medial rectus. This is right lateral rectus and left medial rectus. Now, go for this. What is this? Can anyone tell? Right eye, we are testing inferior oblique, and left eye, we are testing superior rectus. Okay. So nasal up is inferior oblique and lateral up is superior rectus. What is this? This is suppose. What is this? This is left eye superior oblique, right eye inferior rectus. So this is important so that we know which muscle is involved when we are doing the extraocular movement and whether that is corresponding with the cover test or not.
Love, Dr. Love, could you also have a look at the chat box?
One minute.
We can finish a few questions which are here. And
Loose prism is better. Uncovered test, do we look for movement of the covered eye after removing the cover? Yes. We look for movement of the covered eye only after the uncovering, so that we get to know the latent nystagmus. So what are the other questions? Krimsky and modified Krimsky are answered. Then
I just realized that Kunal is taking care of it.
uh,
ठीक है. Okay.
sensory examination first or visual acuity? Ideally, sensory first. Ideally, but that we cannot do because we need to know the vision of the child. Because again, in a visual acuity, we are breaking the fusion. So that question was good. But practically, it is a bit difficult. And what we do the vision of the child, and then we leave the child with binocular vision, and then check the do the sensory evaluation again after some time. Cover. Loose prism is done, and okay. So I'll go back to the presentation.
Yes, please.
And next comes the ophthalmic examination. As I told earlier, full anterior segment pupil in children. If you at least the finger tension should be done, and if we have doubt of ophthalmos, then IOP has to be checked, and fundus evaluation must for every child. Must. It cannot be. No examination is complete without fundus evaluation. Even handheld slit lamp is available now that can be used. Now let's come to some of the investigations that we do. Now, as you see, what is there in this child? Can anyone tell with the ocular movements? So, there is a test called Hess chart, and as you see in this child was having inferior oblique underaction. So, inferior oblique underaction can be due to Brown syndrome. Brown syndrome also can mimic as inferior oblique underaction. So that can get documented using a Hess chart. Same thing can be done for other paralysis like lateral rectus, superior oblique. All that can be documented. So Hess chart and diplopia chart are two investigations that need to be done. This is again very interesting, and you have to understand this properly. If this is for vertical nystagmus. Vertical nystagmus, the most common is superior oblique palsy. So, but that doesn't mean that other vertical muscles cannot be paralyzed. Most common, 90% of the time it will be superior oblique palsy, but you have other diseases also like thyroid eye disease, Brown syndrome, all those can have a vertical component. So for that, we do the Park 3-step test. And what are the 3 steps? First, you do a cover test in the primary gaze and mention it in your chart, the reading of the primary gaze. And whatever it is, then do the same thing in right and left face test. It is a suppose if it is a left hypotropia, and then in right and left gaze, what happens to that left hypotropia can be documented. And whether it increases in right or left gaze or not, and same thing has to be done in head tilt, whether it increases or decreases. And once you have done this, then do all the extraocular movements. That will help us in diagnosing the vertical squint. And you can go through the charts available as to in superior oblique palsy how it will act and what will be the interpretation of this test. And then comes force reduction. Whenever we are operating for a squint, this is must, force reduction test, because that may not be possible to do in OPD. So that part has to be completed in the OT before we give the conjunctival incision. And how do we do it? For rectus muscles, up, down, right, left is for rectus muscles. But for obliques, the intorsion, this is test for superior oblique. Press the eye and intort. This way we test for superior oblique, whether it is having any restricted movement or not. So this is again very important when we are doing any squint surgery. This forms a part of the squint evaluation. That's all regarding the evaluation of the squint. Thank you. We'll take questions now.